rare and synergy of scoliosis-specific exercises and adolescent idiopathic scoliosis treatment.
Hello. No disclosures. So BRACE study confirmed the BRACE effectiveness and established a dose-response relationship with an average BRACE wearing time of 13 hours was associated with almost 90% of success. We all know that full-time bracing remains challenging in real-world practice due to treatment burden, psychosocial stress, and school participation issues. Therefore, defining a minimum effective brace dose may provide more individualized and adherence-friendly treatment. So our objectives was to investigate this dose-response relationship, identify the MEBD for treatment success, and explore whether scoliosis-specific exercises frequency could modify the probability of success. We did a retrospective study from a prospectively clinical database using the SRS research criteria for bracing, recruiting 168 patients. And the treatment protocol was CINO 3D brace and individualized brace prescription according to the risk of progression, plus scoliosis-specific exercises 5 days per week for 30 minutes. Our outcome parameters, success or failure, model-based predicted probabilities, threshold identification for MEBD, and subgroup-specific dose-response patterns. We stratified our baseline Cobb angle into 3 categories, 25 to 30, 30 to 35 degrees, and 35 to 40. And we also did a division for the mean brace wearing time in quartiles. So we had quartile 1 with an average 11 hours, 2, 14 hours, 3, 16 hours, 4, 18 hours. For statistical analysis, we use ROC, Uden-J statistic, multivariable logistic regression, and Bootstrap-Wilson 95% CIs. The average brace wearing recommended brace wearing time was 16.7 hours, and our patients wore the brace for 14.5, doing the exercises approximately 3 days per week. We found a stability in the thoracic Cobb angle and a significant improvement in the lumbar Cobb angle. Overall, we got 33% of improvement, 55% of stability, and only 12% of progression. And we noticed that in the lower strata, 25 to 30 degrees, we had more improvements, while in the higher strata, we had more progression as expected. A dose-response pattern was observed with longer brace wearing time associated with better outcomes, going from 74% of success with 11 hours to 95% at the highest at 16 hours. We also noticed the same pattern for improvement, having a highest rate of 42% of improvement with 14 hours of mean brace wearing time. The Uden threshold analysis suggested the minimum effective brace dose of approximately 14 hours per day for the whole cohort, and higher PSSA frequency showed a trend toward association with better outcomes. In our logistic regression analysis, we found the brace wearing time as the only independent predictor of overall success, while PSSA frequency and interaction with brace showed borderline non-significant trends as predictors of success. For improvement, we found the in-brace correction as the only independent predictor of improvement. So our baseline severity stratification showed that a stepwise increase in suggested MEBD was observed with increasing baseline Cobb angle severity. So we found that most of the patients with 25 to 30 degrees, 14 hours were enough for them. For 30 to 35 degrees, 16 hours. For 35 to 40, approximately 18 hours. So to conclude, a clear dose-response relationship was observed with greater brace wearing time associated with better outcomes. The ROC-Uden analysis suggested an overall minimum effective brace dose of approximately 14 hours per day. Brace wearing time was the only independent predictor of overall success, while PSSA frequency showed a borderline but not significant trend. And we noticed that higher Cobb angles may require progressively great brace wearing time. Take-home messages. In this PSSA-supported cohort, clinically meaningful results with almost 90% of success achieved with part-time bracing around 14 hours a day. Our findings support a more personalized and adherence-friendly approach to bracing than the traditional strict full-time model. And I think the ultimate goal should be to achieve the best possible outcome with the least possible treatment burden for the patient. Thank you.
Great, thank you. 3 great talks so far.